Welcome to the virtual 2021 APSA session on trauma. I am Dr. Chetan Sathya from Cohen Children's Medical Center, Northwell Health, and I'll be one of your moderators today.
Good evening and greetings from Northern Nevada. I am Dr. Frida Holka. I am the Director of Pediatric Surgical Services at Renown Children's Hospital and also Associate Professor of Surgery at the University of Nevada School of Medicine.
Our first abstract today will be presented by Dr. Joseph Wirtz from the Division of Pediatric Surgery, UCLA. And his abstract is titled, A Comparison of At-Home versus Away from Home Youth Suicides.
This presentation is a comparison of at-home versus away-from-home youth suicides and the implications the findings have for prevention efforts. My colleagues and I have no conflicts. As the graph front and center shows, youth suicide is on the rise in the US. Unfortunately, communities today are suffering the greatest burden of youth suicide experienced in at least the last 2 decades. In 2019, suicide was the second leading cause of death among youths 9 to 18 years old. More children in this age group took their own lives than died of neoplasms, congenital anomalies, heart disease, and lung disease combined. Previous youth suicide research has stratified incidence by several factors, including race, age, and means, in order to devise and inform targeted prevention efforts. To date, however, the academic community has yet to elucidate how youth suicide characteristics differ, if at all, according to where the fatal attempt is made. To begin to fill this gap, my colleagues and I sought to characterize and compare the who, how, and where of at-home versus away-from-home youth suicides. Without a proper understanding of the relevance of the location of youth suicides, it cannot be known how generalizable and effective certain prevention strategies might be. As such, it was also our aim to contextualize our findings for contemporary prevention strategies. Data for our study come from the 2005 to 2017 National Violent Death Reporting System, which is a state-based surveillance system developed to monitor homicides, suicides, and firearm deaths of undetermined intent. In 2005, 11 states participated. By 2017, the most recent data year available, 32 states were reporting. We queried the NVDRS for all suicide victims 18 years and younger. Next, we dichotomized these deaths according to where the fatal injury occurred, either at the victim's place of residence or elsewhere. We also linked county-level socioeconomic data from the American Community Survey to each death. We then used multivariate logistic regression to compare away-from-home versus at-home youth suicides, controlling for victim, incident, and community characteristics. In total, we identified 7,939 youth suicides. Of these, 73% occurred at the victim's home, and 27% occurred away from the victim's home. Victim and incident characteristics of at-home and away-from-home youth suicides were similar. An overwhelming majority of victims were male, and most tended to be white teenagers without a prior history of suicidal thoughts or attempts. The counties in which these suicides occurred were not exceptionally rural nor poor. Of note, however, while the majority of at-home youth suicides were hangings, the plurality of away-from-home youth suicides were firearm suicides. Multivariate analysis showed that youths who made the fatal attempt away from their home, as opposed to at their home, were significantly more likely to be older, non-white males with a prior history of suicidal ideation or attempts. Rather than hangings, away-from-home youth suicides were significantly more likely to be firearm suicides, or involve different means, such as jumping. Lastly, the counties in which away-from-home youth suicides occurred were significantly more likely to be rural and poor than the counties of at-home suicides. In conclusion, youth suicide is not a problem confined to the home. 1 in 4 youths who died by suicide made the fatal attempt elsewhere. Accordingly, research, risk screening, and prevention efforts must consider both the home and community environments. For example, while current pediatric guidelines recommend screening for household firearm access, clinicians should also consider a youth's exposure and access to firearms elsewhere, especially in the context of mental health issues. And finally, just like how the trauma, engineering, and urban design communities worked cooperatively to successfully reduce roadway injuries and deaths, diverse stakeholder involvement will be needed to comprehensively combat the rise in youth suicide, especially the deaths that occur away from the home. Thank you.
Thank you, Dr. Wirtz. The invited discussant for this abstract is Dr. Ryan Spurrier from the Children's Hospital of Los Angeles.
Congratulations on that excellent presentation, Mr. Wirtz, to both you and your collaborators. I'm just curious initially, how do you think the recent changes with the COVID pandemic might affect your findings?
Yeah, thanks for having me here too. The COVID pandemic is an interesting interaction with the youth suicide. It's tough to say as of now how it might affect the distribution between at-home versus away-from-home youth suicides. We can imagine with the stay-at-home orders that the at-home might be disproportionately elevated in 2020. That being said, youth suicide overall, preliminary reports, for example, a study published just last month in Pediatrics, showed that in certain months in 2020 compared to those same months in 2019, youth suicidality, both suicidal ideation and suicide attempts, was increased. Although we did not see a universal increase in youth suicidality for 2020 in the months of the COVID pandemic compared to a baseline as measured in 2019.
Very interesting. I guess time will tell.
Mm-hmm.
So just in general, what would you consider to be a successful or effective prevention strategy?
Yeah, so with suicide, it's very difficult to predict suicidal ideation in individuals, and it's difficult to predict who might attempt suicide. So a successful prevention strategy really relies on making it hard for an individual to die by suicide. And perhaps in the context of youth suicide especially, restricting access to lethal means seems to be by far the most important and successful prevention strategy. So in the context of at-home versus away-from-home youth suicides, we see that firearms are especially an important avenue for prevention.
And then finally, based on what you've discovered thus far and what you've read in the literature, can you at all hypothesize what locations might be most beneficial for targeted prevention efforts? Yeah,
sure. And so one point that I really want to make clear, and kind of goes back to my last answer too, is that the plurality of away from home youth suicides are firearm suicides. And so when we look at where the firearms come from in youth suicides overall, we see that 60% of firearms come from the victim's home. And then an additional 15% come from the homes of relatives and friends. And so if we want to make an impact on youth suicide overall, and even away from home youth suicides, we need to make sure that the home environment is a safe environment and one that makes it difficult for youths to acquire or access lethal means. Beyond the realm of firearm suicides, we also see that many youth are dying by jumping from high places. And so that represents an important avenue for community leaders, urban design engineers, and trauma surgeons to coordinate efforts to prevent and put up barriers in locations where it might be possible for somebody to die by suicide.
Well, I couldn't agree more. And again, I want to commend you and your co-authors for tackling what is a huge, huge problem in the lives of youth throughout our country. So thank you again for your time and excellent work.
Thank you again for the opportunity to present our work, and we look forward to hearing all of the other great presentations. And thank you again.
Cheers.
Thank you, Dr. Wertz, and thank you, Dr. Spurrier.
Our next presenter will be Dr. Nidhi Shahi from Children's Colorado, who will be presenting Rethinking Pediatric Trauma, Risk Stratification and Predicting Need for Massive Transfusion Using Machine Learning for Blunt and Penetrating Trauma.
Thank you for the opportunity to present our work. We have no disclosures. Trauma is the #1 cause of mortality in children, and up to 7% of traumatically injured children require blood transfusion. There's a high mortality rate, up to 27% of children who need massive transfusion. Overall, there's limited literature on MT triggers in children. The following scores have been proposed, but none have been widely adopted. The ABC score has been found to have low sensitivity in children. The goals of our study were to use deep learning, a subfield of machine learning, and natural language processing to develop 2 models. Model 1 was a high-risk model to predict massive transfusion, and Model 2 is a low-risk model to predict that no blood transfusion was needed. I'm going to give some definitions before I go into the methods of the study. Machine learning is a form of artificial intelligence, and it has the ability to learn rules and apply them to a data set it hasn't seen. A machine learning model transforms input data into meaningful outputs. A process that's learned from exposure to known examples of inputs and outputs. However, it does require feature engineering. Deep learning is a subfield of machine learning that employs successive layers of increasingly meaningful representations from multimodal inputs, including numerical data, text, images, audio, and video. And it makes problem solving easier because it automates feature extraction step in the workflow. Natural language processing, or NLP, is a subfield of AI that is focused on enabling computers to understand language and extract information from it. For example, this is the following paragraph about London, and NLP can extract the pertinent points from this paragraph about London, as you can see on the right. In this study, we used Children's Hospital Colorado Trauma Registry and included all children with blunt penetrating trauma from 2009 to 2019. And we used a variety of features, including numerical features like demographics, vital signs, and laboratory results, in addition to text features such as injury mechanism, diagnosis, and region of injury. This is a risk stratification algorithm that we developed. We first wanted to identify who would need massive transfusion with Model 1, and of those who did not require massive transfusion, Model 2 distinguished those who required no blood transfusion from those who did. This is a graphic demonstrating the approach that we used for this study. We used a combination of numerical and categorical data with demographics, vital signs, and lab values, in addition to text input data. An example of the text input data is shown on the right. The text input data was interpreted with Google's BERT NLP model to create embeddings, which are basically like vectors in numerical data form. And the combination of the numerical inputs and embeddings were used by the artificial neural networks to make predictions on the need for massive transfusion or blood. ANN, or the artificial neural network, extracts information from training examples and builds small linear equations to separate boundaries between 2 classes, whereas the NLP models understand semantics and meaning, but it lacks understanding of numbers. This is why we used a combination of both artificial neural networks and BERT NLP to develop these models. When we looked at linear relationships between lab values and vital signs in massive transfusion, you can see that most of the correlations are very weak. This slide demonstrates the performance of the 2 models. And as you can see, our models had high accuracy, sensitivity, specificity, AUC, and F1 scores. We had a total of 1,048 patients. Overall, 83 patients required massive transfusion, and Model 1 predicted that 151 out of 1,048 required massive transfusion and missed 3 patients who required massive transfusion. In total, 817 patients didn't need blood, and Model 2 correctly stratified 775 out of the 817 who didn't need blood. When we compared the deep learning massive transfusion model to the APSAsode score, the score that had the highest sensitivity and specificity to predict massive transfusion, you can see that there was a higher number of true positives and fewer false negatives in the high-risk deep learning model compared to the APSAsode score. We also did take a look at the false positives from our model, meaning where our model predicted massive transfusion, but the patients didn't receive massive transfusion. There was overall 71 false positives, and there were 40 patients in this group who received more than 20 cc's per kg in 6 hours, and 63 who received more than 10 cc's per kg in 6 hours. So while these patients didn't meet massive transfusion criteria, the model did pick up on patients who did require a significant amount of blood. Some other themes from our review were that many of these patients had severe TBIs. Many of them had hypotension that was unlikely from hemorrhagic shock and was more likely related to their severe TBI. And there were many who died shortly after admission. Conclusions. Our study shows that there's feasibility of development of deep learning stratification models to develop high risk and low risk patient populations. It also highlights some of the limitations with the current scoring systems to predict massive transfusion. Thank you so much for listening and happy to take any questions.
Thank you, Dr. Shahi. The discussant for this paper will be Dr. Aaron Jensen.
Thanks, Dr. Shahi. That was a phenomenal talk, exciting work. I'm really excited to use machine learning in our trauma bay here. I'd love to implement it. I have a few questions about your work. The first one is really about the sensitivity and accuracy of your model. I noticed that you used a lot of variables that were available later on in the resuscitation, like the AST, ALT, COAG studies, and perhaps even final diagnosis. We know from the proper study that time to that first cooler, and we're talking minutes, it really impacts mortality with massive transfusion. So I'm wondering, did you have the opportunity to apply your model only to variables that are available early in the resuscitation, like physical exam findings, perhaps maybe a chest x-ray finding or vital signs? And how does that impact your the performance of the model so that perhaps we could use that earlier on in the resuscitation?
Thank you so much for your question. We agree that time to MT activation is critical. And in the study, we used a combination of features that are immediately available and some that may take an hour to return, but are still available in the emergency department, such as tags, labs, and the ultimate diagnosis. And there are limitations to this approach with a potential delay of data availability. However, some institutions do have ISTAT labs available, which could possibly be incorporated more rapidly in future studies. And some of the variables that we use that were immediately available included the demographics, vital signs, volume of blood resuscitation en route, SIPA score, GCS, intubation status, and FAST exam. We did find that the correlation for most individual variables and need for massive transfusions was low, which highlights the utility of machine learning and understanding these complex nonlinear relationships. We did ultimately test the model with numerical features only compared to numerical and text features, including diagnosis and imaging findings. And we found that there was about a 90% accuracy, 91% sensitivity, and 90% specificity with the model with just numerical features. And when we included text and numerical features, the model had a 92% accuracy, 96% sensitivity, and 92% specificity, which shows that the model improved with addition of text features. But I think finding ways to incorporate the data more quickly so it can be applied in real time is really important.
Yeah. Can you expand a little bit on the text that you included? Did you, I mean, it sounds like you used trauma registry and perhaps chart notes. What chart notes did you use? I mean, does it include the discharge summary? Because clearly if you have all the information from the hospitalization, your model is going to be very good. Or is this just that narrative that you get from EMS?
Yeah, thank you for your question. We used language processing to evaluate text features for injury region, mechanism, and diagnosis from our institutional trauma registry. And this was used to create a computer-generated note from the text columns. So some examples of like diagnosis codes that we ended up using were like a grade 5 spleen injury, traumatic subdural hemorrhage, or a burn of 20 to 29% TBSA. And an example of a computer-generated note that our model used as a text input included the following: 7-year-old male, 16 kilograms, diagnosis, bilateral hemorrhagic contusions. Mechanism was a motor vehicle passenger, injuries head, INR is 1.49, SIPA is normal in the ED, R from the TEG is unknown, base deficit -2, and then so on. And this was basically how the text features were used and the sort of narrative that the computer was able to generate. And I think richer input data would probably improve the algorithm performance further, but we didn't specifically look into that. And then when we did compare the machine learning model with numerical features to numerical and text, we found that the numerical and text did better, but we didn't specifically look at text features alone.
Yeah. I'm also fascinated about, the whole concept of trauma room mics and the mic'd up surgeon, and can the computer get inside my brain? What do you know about the applicability of this type of machine learning to audio recordings? And I'm just trying to think about, rather than using the registry, can I use this in my trauma bay? And is there a way that we can apply machine learning to real-time data inputs, including human text, and have the computer recognize things that we're not using as another safety mechanism? Is that anything that you've worked on or seen coming down the pipeline?
Our models were developed in PyTorch with the Hugging Face transformers and Google Colab after the data was de-identified. And the natural language processing models were used with Google BERT. Deep language architecture supports multimodal models, and the power of this approach is that you can use numerical data, text data, imaging, and other relevant inputs like audio. It's not just limited to text, which is pretty cool. And analyzing speech is doable, but it is technically more complicated. Yeah. And there's two. There's two different approaes to this. One is directly using the audio data, and so the system can pick up the audio via microphone, compute it via MEL spectrogram. So basically the sound is used as an input that's used by the machine learning model in two different ways, with image classification with the neural networks, and then natural language processing with embeddings. And then another way is to use the audio, convert the speech to text with a cloud-based AI approach, and then use text inputs like we used in our model. But it is a bit complicated to do this because you need like a big training database with all this audio data, which we didn't use for this study, but I think it'd be something very interesting to look into in the future with real-time application potential.
Sounds like you have your work cut out for you. Well, thank you for your time. I think we've used up our 4 minutes. Again, fascinating work, and congratulations on getting this study done.
Thank you so much.
Thank you, Dr. Shahi and Dr. Jensen. Our next presenter will be Dr. Kayla Briggs from the Children's Mercy Kansas City Hospital. She'll be presenting an article on outcomes after pre-hospital traumatic cardiopulmonary arrest at a level 1 pediatric trauma center. Take it over, Dr. Briggs.
Thank you for the opportunity to present our work. None of the authors have any disclosures. It's no secret that the outcomes in traumatic pre-hospital arrest are abysmal. The survival in children is estimated to be between 0 and 25%, and young age is not protective when compared to outcomes in adults. In 2014, the ACS Committee on Trauma, in conjunction with the National Association of EMS Physicians, the American College of Emergency Physicians, and the AAP released a statement on this topic. They concluded that more research was needed on the outcomes in children suffering from pre-hospital traumatic arrest in order to produce legitimized guidelines to include children in termination of resuscitation protocols. We anecdotally observed what seemed to be prolonged resuscitation attempts in children brought to our facility having pre-hospital CPR initiated for traumatic arrest. This led us to ask, what are their outcomes? How long do their resuscitations last? And how can we best provide evidence-based, patient-centered care to the most critically injured children? This was a single institution retrospective review of children ages 0 to 17 years that had pre-hospital CPR initiated for traumatic arrest from May 1st, 2009 to March 1st, 2020. In total, 48 children were identified as having pre-hospital CPR initiated for traumatic arrest. Only 6, or 12.5%, survived to discharge. 25 children were still undergoing CPR upon arrival to our facility, while 23 had attained pre-hospital ROSC. Children that did not have pre-hospital ROSC were more likely to die, as no child undergoing CPR presentation survived to discharge. When examining the outcomes of the 23 children that attained pre-hospital ROSC, 1 was admitted to the floor, 1 went directly to the operating room, and 21 children were admitted to the PICU. The child that was admitted to the floor, the child that went directly to the operating room, and 4 of the children that were admitted to the PICU survived to discharge with a median length of stay of 38.3 days. The remaining 17 children died after a median length of stay of 4.9 days. When examining the outcomes in the 25 children that were still undergoing CPR presentation, 8 attained ROSC in the trauma bay and were admitted to the PICU. Ultimately, 100% died after a median length of stay of 24.5 hours. The remaining 68% of children died in the trauma bay after a median total CPR time of 34 minutes. The age, ethnicity, and activation type did not differ between those who did and did not attain pre-hospital ROSC. We did, however, note that more children that attained pre-hospital ROSC were transferred from outside facilities. The type of injury did not differ between groups, nor did the specific mechanism of injury. When examining the outcomes of the 6 children that survived to discharge, all had a GCS score of 15, but all required some form of services at discharge. The 1 child that survived a motor vehicle collision still struggles with psychiatric issues. There were 2 victims that were struck as pedestrians, one of whom has very minimal deficits, the other that struggles with mobility. There was 1 child that survived a non-accidental trauma that still struggles with cognitive delays. There was 1 child that survived a hanging that still struggles with depression. And there was 1 child that was originally thought to be a victim of non-accidental trauma, but was later confirmed to have metapneumovirus leading to a code event that still struggles with hemiparesis. In conclusion, not attaining pre-hospital ROSC was associated with 100% mortality in our study. Those who did attain ROSC once at our facility universally died in the PICU. Those who survived required varying levels of care after discharge, but all had a GCS score of 15 and eventually were able to live at home with their caregivers. We agree with translation of adult termination of resuscitation protocols to children. We understand that the termination of resuscitation attempts in a critically injured child is emotionally loaded and difficult. We hope our data empowers trauma providers to provide evidence-based, patient-centered care when futility is evident during resuscitation attempts. Thank you. I would now be happy to take any questions.
Thank you, Dr. Briggs. The discussant for this paper is Dr. David Notrika.
Dr. Briggs, thank you. That was a great presentation. I really appreciate the work that that you guys do in Kansas City. I do have a few questions for you. Of the children that died, how many of those were ultimately organ donors? So did any of them actually donate, or were they donation after cardiac death donors? The second question is that the adult literature shows that that survival is really a lot higher for penetrating trauma. And it looks like that of the 48 children that you enrolled in the study, only 3 were penetrating. So with so few children having penetrating injury, do you think your recommendations still apply for penetrating trauma? And then what's your standard approach to patients who arrive in cardiac arrest after abdominal trauma? So specifically, do you give them a trial of blood? Do you place empiric chest tubes? Do you do a chest x-ray or a fast exam? Or do they just get compressions until the code ends? And then did any of the 3 penetrating injuries receive an emergency department thoracotomy? And then the final question is, were you able to determine the cause of death of non-survivors? So is there a pattern of injury that predicts a non-resuscitatable patient? Again, thank you for this great work.
Yeah, thank you so much for the opportunity to present our work and to participate in the question and answer session today. To answer your first question, a total of 13 children from the non-survivors went on to organ donation. 2 drowned, 3 were victims of non-accidental trauma, 3 were involved in motor vehicle collisions, 2 committed suicide, 1 was attacked by a dog, 1 was shot in the head, and another child was crushed while working underneath a vehicle. They had a median CPR to ROSC time of 20 minutes with an interquartile range of 15 to 30 minutes. To answer your second question, there were, of the 3 children that sustained gunshot wounds in our cohort, 1 was shot in the head. He underwent CPR for a total of 16 minutes prior to attaining ROSC and ultimately went on to become an organ donor. Another child was also shot in the head, and he was declared dead in the trauma bay after undergoing resuscitative efforts for 30 minutes. The last child was shot in the bilateral legs and buttocks several times and underwent CPR for a total of 30 minutes prior to being declared dead. He had an unknown downtime and had no witness signs of life on EMS arrival. We believe the recommendations should still be applied. We know that victims of penetrating trauma typically have a potentially reversible or fixable injury. And so, whether that's placing chest tubes, giving blood, doing a thoracotomy, going to the OR and fixing that reversible cause of bleeding. But we know beyond those 30 minutes that the neurologic outcomes are just not good. And so we don't believe that the specific mechanism of injury should be a deciding factor unless there's something that you're actively working on, like a complex vascular injury, a complex portal injury that can potentially be fixable in that case. With regards to the third question, we do not have any institution-specific protocols outside of following just general ATLS principles. For blunt abdominal trauma, we advocate for early bilateral chest tube placement and blood transfusions. With regard to the fourth question, only 1 child was potentially a candidate for emergency department thoracotomy. It was that child that was shot in the bilateral thighs and buttocks. The documentation was sparse, but from what we could tell, because the pre-hospital course was so unclear and his downtime was unknown, they did not pursue that further and decided to declare it at 30 minutes. And then to answer the last question, if we were able to determine the cause of death in the non-survivors, unfortunately, many of the medical records that we reviewed did not have autopsies available. And in some instances, because of the mechanism where it was clear, a drowning that had the trauma team involved, an autopsy wasn't performed. We did not specifically look if the pattern of injury was associated with or, not attaining ROSC, but we didn't notice any significant impact of the mechanism having on that. We did note, and understandably, that the majority of children that died had very severe multi-system trauma and or severe neurologic injuries.
Well, I really appreciate those answers. I think that this type of research will really change what we do in the trauma bay, kind of give us set some goals so that we're doing what works, and when it doesn't work anymore, we stop.
Absolutely. Thank you so much. I appreciate it.
Thank you, Dr. Briggs and Dr. Naccd. The next abstract to be presented will be by Ellie Gibbs from the University of California, Irvine. The title of this presentation is Legal Intervention in Children Disproportionately Affects the African American Population. Proceed, Ms. Gibbs.
Hello, my name is Ellie Gibbs, and as part of the CHOC trauma research team, I will be discussing legal intervention as a mechanism of injury in the pediatric trauma population. Legal intervention is any injury sustained as a result of an encounter with any law enforcement official serving in any capacity at the time of the encounter, as defined by the ICD 9 and 10 codes. We queried patients from the National Trauma Data Bank, or NTDB, from 2007 to 2015. We used the ICD codes for legal intervention for patients under 19 years old to investigate mechanism of injury and sociodemographic variables of legal intervention patients compared to the general pediatric NTDB population. We then performed analysis within the legal intervention group for injuries related to firearms. Of the approximately 1 million patients in the NTDB, 622 received trauma due to legal intervention. Of those 622, 30 had died and 312 had firearm trauma. Compared to the general pediatric trauma population, legal intervention patients are older and more likely to be male and African American. They are also less likely to be white or Asian or Pacific Islander. Legal intervention patients are also taller, heavier, and more likely to test positive for substance use. They also have a higher mortality rate. Of the patients who had died due to legal intervention trauma, African American children were more likely to die than non-African American children. Additionally, mortality was significantly higher when a firearm is used rather than another mechanism of injury, such as blunt force trauma. Within the legal intervention subset, 312 patients were injured due to a firearm. These patients were typically older and male. African American children were more likely to have a firearm used against them than any other mechanism of trauma. Contrary, white children were less likely to have a firearm used against them than not. Drug use was not associated with likelihood of firearm use, and in fact, alcohol use was associated with reduced chance of firearm trauma. While there was no difference in age, height, or weight between African American and white patients who received legal intervention trauma, there was a significant difference in size of African American patients who had firearm trauma and those that did not, an effect not seen in white patients. There was no association between African American status and positive drug screening results, and there was a reduced odds of this group testing positive for alcohol compared to other races. The proportion of legal intervention trauma did not significantly vary until after 2013, when it significantly decreased 27% in 1 year. While we did not investigate why this trend is seen, it is worth noting the Black Lives Matter movement and similar political movements were established in 2013. To conclude, legal intervention rarely occurs in the pediatric population. However, the mortality rate among legal intervention patients is 4 times higher than the general pediatric trauma population. This is consistent with our finding that mortality increases when firearms are used. African American children are more likely to have a firearm used against them than not, and height and weight are associated with firearm use and mortality for African American children. These trends are not seen in white children. Legal intervention patients are more likely to test positive for drugs and alcohol than the general trauma population. Within the legal intervention population, there is no association between African American patients and positive drug screening. They are less likely than all other races to test positive for alcohol. Thank you for your time and to the rest of the research team whose information is below. My contact information is below for any questions. Thank you.
Thank you, Ms. Gibbs. The discussant for this paper will be Dr. Kim Wallenstein.
So thank you for your excellent presentation of this compelling data. I have two questions. First, were you able to get any information about geographic variables? Was it or would be possible to get information about states or zip codes? And my second question is, where do you go from here? What action items do you see coming out of this data? And again, thank you again for your presentation.
Well, thank you for listening, Dr. Wallstein. I appreciate the time you spent. And actually, the answer to these questions are linked. So we were planning initially to include geographical data in the form of zip codes in this study to see if the rates of legal intervention trauma were higher or lower in specific areas due to either over-policing or perhaps socioeconomic status, or perhaps maybe voter registration status. However, due to COVID-19, the data requesting is really high right now, and a lot of people are trying to get data from different databases right now. So we weren't able to get it for this paper, but we do plan on looking into this in upcoming papers once we're able to get our hands on this data and to investigate urban versus rural and socioeconomic status, like I said earlier, and political and socioeconomic effects on different communities to see if they will affect rates of legal intervention on the pediatric trauma population.
Right, and then any other action items that you get out of this? What kind of messages do you think you send to the community, or how do you disseminate this data to make it more widely known?
For sure. I mean, so we are coming from a children's hospital, the Children's Hospital of Orange County. So it was important for us to look at the pediatric population, the pediatric trauma population specifically. However, it would be interesting to see how these trends extend beyond the pediatric population, to see if what we're seeing in pediatrics applies to adults, if what happens in adults applies to pediatrics as well. Furthermore, in this study, we looked at, for example, physical attributes, height and weight, and whether or not they affected the likelihood, and it turns out they did in some cases, of a child being affected by legal intervention trauma. And perhaps there would be other forms of attributes or socioeconomic variables that we could investigate in the future.
Excellent, thank you.
Appreciate your time.
Thank you, Ms. Gibbs and Dr. Wallenstein. The last paper in our session will be presented by Dr. Mira Kodagal from Cincinnati Children's Hospital. The topic will be upstream targets, social deprivation, and increased violence-related pediatric injury. Proceed, Dr. Kodagal.
Thank you very much for the opportunity to present our work today. We have nothing to disclose. As we all know, injury is the leading cause of death and disability for children worldwide. Significant disparities in risk and outcome have also widely been described, and these racial, ethnic, and insurance-related differences suggest that there are broader contextual factors driving who gets injured and how severe those injuries turn out to be. We expect that many such drivers of pediatric injury are rooted in the social determinants of health. Additionally, research has shown that toxic stress resulting from neighborhood context, as well as adverse childhood experiences, increases both the risk for injury as well as lifelong health inequities for children. Our group has previously demonstrated a strong correlation between rates of pediatric injury-related hospitalizations and neighborhood-level deprivation, pointing at the ways in which neighborhood context increases risk of injury for children. Our objective for this study was to assess the relationship between deprivation and violence-related pediatric injury at the neighborhood level, hypothesizing that neighborhoods with higher rates of deprivation would also have higher rates of violence-related injury. We conducted a retrospective review of all children 0 to 16 who were admitted for pediatric injury between 2010 and 2019. For this analysis, we focused on children who were victims of abuse and assault as violence-related injuries. We geocoded each patient's home address to quantify injury at the neighborhood level. We used a socioeconomic deprivation index as a composite measure, and census tracts were then divided into tertiles of deprivation for comparison in this analysis. 6,324 independent admissions were included in our final cohort. The median age of the patient population was 10, and patients with violence-related injuries were in the youngest and oldest age groups, demonstrating the extremes of age related to abuse and assault. The overall cohort was 57% white and 38% Black, while children who experienced violence-related injury were significantly more likely to be Black, making up 60% of that portion of the cohort. Patients with violence-related injuries were also significantly more likely to have public or self-pay insurance compared to the overall cohort. Violence-related injuries made up 6.2% of all injuries, and the types of mechanisms were varied by age group, depending on how old these kids were. We then compared the percentage of injuries that were violence-related across the 3 tertiles of deprivation and found significant differences. Violence-related injuries comprised 3.8 times more injuries in the highest deprivation tertile when compared to the lowest. The most notable limitation for our work is that we cannot account for pediatric patients who were hospitalized at other centuries for injuries. We attempted to address this by limiting our analysis to Hamilton County, where we are the only level 1 trauma center and admit greater than 95% of all children who require hospitalization for injury. Secondly, we used an area-based measure related to socioeconomic deprivation as a surrogate for the multitude of social determinants of health that may influence injury, recognizing that this may oversimplify an exceptionally complicated interplay between social factors and injury. And lastly, we focused on abuse and assault injuries in this assessment of violence-related injuries, but acknowledged that self-inflicted injuries are also injuries of despair and are also likely tied to toxic stress. Future work will focus on this population. In conclusion, we found that increased community deprivation was associated with higher rates of violence-related injuries in children, and our results suggest that social determinants of health may serve as valuable targets for upstream intervention. Notably, while we found race-related differences in our cohorts, we believe that these differences are related to structural racism and historic practices such as redlining that have led to higher rates of people of color living in neighborhoods of higher deprivation, not any intrinsic factors linked to these individuals themselves. Importantly, it is crucial that research such as ours be paired with interventions and efforts to address these root causes. And in that vein, we have had our community partners with our work throughout, and we're continuing to build our community team, identifying one neighborhood where we'll begin to focus, building our theory of improvement and designing and testing interventions to hopefully identify those that will be most effective at addressing root causes and reducing pediatric injury. Thank you very much for the opportunity to present our work today, and I'd like to acknowledge our team and particularly our community partners in this work. Thank you.
Thank you, Dr. Kodegal. The discussant for this paper will be Dr. Reagan Williams.
Thank you, Dr. Kodegal, for an amazing presentation. This work is really, really interesting, and I think it's going to have such a profound effect on how we prevent violent injuries in our patients and also how we improve community violence overall. I have a few questions for you. The first one is, how will you use this data to prevent violent injuries within your community?
I think it's a great question, and I sort of touched on it at the end of the presentation, which is that it's really important that any of the research work that we do that focuses on these topics isn't just research for the sake of doing research, but actually is paired with interventions to try to have an impact. So you're not just documenting disparities and inequities, but actually doing something about them. So we are working on doing community-based participatory research for this work. And so we have a community team that's partnered with us, and we, in the second year of the work that we're doing with this, we're starting to really engage in one community. And our goal is to try to work within that community to identify social determinants of health and root causes that we can address at the community level, whether that's food security or housing related things, components of the built environment that may contribute to those injury rates and to stress, and then trying to really start to ameliorate that at a community level by using equity-based quality improvement. So trying to test changes and see whether at a small level we can identify some changes that make an impact over time for families, and then try to hopefully spread that and grow that in our region.
How did you identify that one community that you're working in?
Yeah, so we actually went through and created a list of criteria for ourselves about what we thought was most relevant. So we wanted a community that was small enough where we felt like we could have an impact, but big enough where we would be able to measure change. We wanted to pick a community that had higher rates of poverty and higher rates of minority citizens, just recognizing that in some of our other research, we've seen the linkages there with the disparities reflective of structural racism and other issues that we see in our communities. And then we took all the neighborhoods and we looked at admission rates and what kinds of injuries they were having and age ranges for those populations, poverty rates for each neighborhood, and narrowed it down to 10, and then started talking about where were our partnerships, where did we know people, where we felt like we could be engaged, and what spaces were too crowded and what spaces were really open to us sort of engaging. And so that's allowed us to kind of slowly work our way towards narrowing to identifying a community. And now the next step is really talking to partners in that community and figuring out, is this meaningful? Is this work relevant to them? Does it align? And how can we co-design equity-based improvements?
All right, the next question. Were you able to divide the types of violent injuries to obtain more granular data? And was the same correlation true when you divided the different injuries up as you found when you grouped them together as violent injuries?
Yeah, so we were able to do that. We had, all the mechanisms of intensive injuries. We were able to divide them into abuse, assault, related injuries, and we saw the same trajectory for each of those. We didn't do a statistical analysis on each of those individually because our numbers start to get a little small. But basically, from as you go up by tertile, we see a doubling in the percentage of injuries that are related to violence-related injuries in each of the categories. So same was true for abuse and for assault and for gun-related violence.
All right. And then you talk a lot about lower deprivation scores correlating with higher stress. And I was just wanting you to comment on the data that supports that. I think it's probably from previous work. And does higher stress really equate to more violent injuries?
Yeah, so some of that is really well studied and has lots of literature to support it, and some of it is, I think, theoretical linkages that we can make. So Patrick Sharkey, Robert Sampson, and others have done a lot of work to document the ways in which deprivation correlate with higher stress, and it's particularly around the concept of toxic stress and neighborhood-related toxic stress. And so there's literature that also supports increase in acute stress for individuals from lower socioeconomic status. And so both of those play a role here. And that toxic stress that we talk about, that Robert Sampson and Patrick Sharkey talk about, really manifests as neurodevelopmental changes. So you can see impacts on the prefrontal cortex, the hippocampus, the amygdala, chronic inflammation, circulatory system as early as 1 month of age for children growing up in neighborhoods of deprivation. And in addition to those neurodevelopmental changes, you can actually see epigenetic changes. So if you look at the telomeres for people growing up in neighborhoods of deprivation, they have changes that are related to that stress. And that stress can have an impact on executive functioning, emotional regulation, stress regulation, and increases risk for mood disturbances and substance abuse disorders. And so we make extrapolations. We do see that neighborhood exposure to violence and adverse childhood events, the ACEs that people talk about, are independently correlated with later rates of incarceration and violence in individuals. So we can kind of extrapolate that stress may be related to violence-related injury, although I'm not sure that anyone has totally done that study to say, if I take people with higher rates of acute or toxic stress in neighborhoods of deprivation, do we legitimately see higher rates of violence injury? But we do know that we see those changes in executive function and other, impulse control, frontal function that we think are associated with things that result in injuries and in violence in communities.
I think we are at the end of our time. Again, really appreciate your work and look forward to seeing what else comes out of this. Thank you.
Thank you so much.
Thank you, Dr. Kodegal and Dr. Williams. I would like to encourage everyone to stay tuned for the rest of the Trauma Committee presentations, which include also discussions on rural and rural trauma disparities, PTSD and suicide risk during COVID, deviations from the Brain Trauma Foundation guidelines and the management of TBI, and lastly, disaster management. Again, I'd like to thank you everyone for their participation in these excellent papers that were discussed this evening.
Good afternoon. I'd like to thank the moderators for the opportunity to share with you about rural trauma and rural and socioeconomic disparities today. I'm Aaron Jensen. I'm joined today by Kenneth Sartorelli from the University of Vermont, Vince Duran from Columbia University, and Alf Kennedy from Geisinger Health. Kenneth is going to talk about the problem of rural trauma. Vince is going to take the ball and talk about disparities in access to care, as well as the global impact. Alf has an interesting rural trauma team development course that he's using to improve the transfer times that he's going to talk about, and I'll wrap it up with some exciting stuff coming down the pipeline from EMSC. So with that, I'll hand it off to Dr. Sartorelli.
Thank you, Aaron. 1 in 5 people in the United States live in a rural area, including 13 million children, but 60% of all US trauma deaths occur in these rural areas. Both adult and pediatric patients are twice as likely to die as their urban counterparts. The probability of death, paradoxically, is inverse to the population density, and rural counties tend to have higher death rates from trauma and overall death than urban counties. Access to pediatric trauma centers, as these maps, and adult and pediatric trauma centers, as these maps show, is limited. Less than a third of adults have access to a verified level 1 or 2 adult, trauma center, within an hour of transport time, and it's worse for children, with only 1 in 4 children having access to a pediatric trauma center within an hour. The risks of dying in rural areas are multiple, and the factors that are related to this include higher rates of impaired driving, lower rates of use of protective safety devices such as helmets and restraints, increased gun exposure, increased risks of high-risk behaviors, including obesity, cigarette smoking, and adolescent pregnancy. Opioids are ubiquitous in the rural population, and poverty is higher in rural areas than in urban areas, with over 1 in 4 children in rural areas living in poverty. And there appears to be a tacit expectation of acceptance of injuries associated with a rural lifestyle. When people are injured, the chance of dying at the scene is much higher. This is usually due to high injury blunt mechanisms and lack of restraints. The discovery, the EMS runtime, and the time to first physician interaction are significantly longer for rural patients than urban patients. The hospitals they're taken to often have reduced capacities for taking care of injured patients, especially children. The rural EMS system is very different than that in urban areas. The urban areas usually are staffed by skilled ACLS and paramedic-based people, where in rural areas it's usually volunteers who are trained at the basic level. The rural population is aging, and there's been a decline in the number of EMS people available. Funding has been markedly decreased since the financial crisis of 2008 and still has not returned to the levels of prior to the financial crisis for both training and support of EMS. Reimbursement remains very low for rural areas compared to urban areas. This has led to the closing of rural EMS transport systems. Private equity firms have gotten involved in an increasing number of air ambulance and ground ambulance services. With a low rate of reimbursement of rural patients, there's been movement of services away from rural areas. Rural hospitals are at crisis. The funding, their funding, even though their critical access is much less, and their resources in terms of physicians is significantly lower than that in their urban counterparts. The COVID crisis has put tremendous strains on rural hospitals, and these estimated closures of 700 hospitals at risk has been accelerated. At this point, I'd like to turn things over to Alf.
Thanks, Kenneth.
Oh, sorry.
Health disparities in pediatric trauma outcomes are evident not only in our country, but also on the global scale. And almost 6 million individuals are killed by trauma every year. 1 million of those deaths are in children. And although 70% of the world's population lives in low and middle income countries, they disproportionately represent 95% of annual trauma deaths. While trauma is responsible for 5 to 6% of deaths in industrialized countries, it causes at least 10 to 13% of deaths in developing countries. This is due to inequity in pre-hospital trauma care and triage, emergency department management, and surgical capacity of healthcare systems in developing countries. The most common causes of death in children are road traffic accidents, drowning, fire-related burns, and falls. Injury surveillance is a key element in developing resource and culture-specific interventions to enhance prevention and treatment of injuries. Injury prevention strategies are even more important in resource-poor settings to optimize the use of scarce resources when injury prevention measures fail. In the US, health disparities in trauma and outcomes have been recognized in past years among children of different racial and socioeconomic backgrounds. And causes of this have included different patterns of exposure to certain types of trauma and health insurance inequity, resulting in barriers to prevention and follow-up care. Other potential contributors include access to dedicated pediatric trauma centers, cultural differences in perspectives regarding preventive measures, such as use of motor vehicle restraints, and implicit bias amongst healthcare professionals. One recent study from the National Pediatric Trauma Registry found similar outcomes of death among Black and white children with moderate or severe traumatic brain injury, but increased odds of discharge to inpatient rehab centers and increased functional deficits in speech, locomotion, and feeding among Black children. Another study evaluating pediatric head injury reported higher mortality among African American children compared to white counterparts based on local trauma registry data, but noted no differences at the national level. These two examples illustrate how more studies are required to better understand the underlying mechanisms of inequity in trauma care at the individual and population level so that they can be more specifically addressed. And with that, I'll pass it on to Alf.
Thank you, Vince. Well, as already elucidated by Dr. Sartorelli-Duran, most of the US remains rural by nature. 60% of trauma deaths occur in these rural areas. Individuals suffering trauma in these rural regions are 50% more likely to die than their counterparts in the urban setting. This is a result of disparity of access to appropriate care, such as designated trauma centers or even pediatric trauma centers, and appropriate education of the caregivers within these critical access facilities. Disparities in outcomes may be in part due to variation in resources provided at these local facilities. Rural trauma education may serve to nullify some of these disparities with the aim of improving rural trauma mortality. The Rural Trauma Team Development course is designed to teach knowledge and skills for initial assessment and resuscitation of trauma patients in a resource-limited environment using a team-based approach with emphasis on early initiation of the transfer process. I live in a rural area, namely central Pennsylvania. Our rural trauma center services 3 million lives within 44 counties of rural PA. Our center, which is rural, uses the American College of Surgeons Rural Trauma Team Development course for education of surrounding local hospitals, both within our system and outside of our healthcare system. We have studied the effect of this course on transfer times and mortality before and after initiating the Rural Transfer Team Development course. We, like other centers who have participated in similar studies, have noted a decrease in transfer time, reduced transfer acceptance times, unnecessary imaging, and potential decreased mortality following dedicated education of surrounding facilities using this very important tool. This slide demonstrates some of our results, both before and after the Rural Trauma Team Development course was initiated. Part A of the slide shows a multivariate analysis of transfer time 2 years prior and 2 years after initiating the course. Part B of the slide demonstrates a similar analysis for transfer times before and after based on imaging. As is demonstrated, transfer times are decreased significantly. However, unnecessary imaging can still be a potential problem and increase transfer time. Most facilities still acquire at least one scan, usually a CT of the brain. Other studies, as mentioned, have shown similar results. We have also demonstrated some trend towards decreased mortality, although this was not statistically significant. Lastly, it's important to note that this is not one-stop shopping. We emphasize a continual PI process between this critical care hospitals and our trauma center. And with that, I will hand it back to Aaron. Thank you.
Thanks, Dr. Kennedy. I'm going to conclude today in the final 30 seconds with a preview of what's coming down the pipeline from EMSC. For those of you that are not familiar with the EMSC Innovation Improvement Center, this is a HRSA-funded initiative that's designed to accelerate improvements in quality of care and for kids who are in need of emergent care. And really, it's for whether they're treated at an urban center or a rural center or a critical access hospital. It's wherever the child is, they should get optimal care. The EIC has added an additional domain this year specifically focused on trauma. And within the next year, you should start to see some standardized protocols come out, some standardized educational materials and tip sheets and guides that can be posted in rural ERs. And all of these are being deployed across the PEC Workforce Collaborative and the National Pediatric Readiness Quality Collaborative. Both of these are grassroots efforts that have high penetrance into some of these critical access and rural hospitals. These are materials that are free, and we would like to enlist the assistance of all pediatric surgeons and major pediatric trauma centers to try to engage their referring centers in this program. It's free, doesn't require any cost to join, and really has some high quality educational materials to improve the care for children wherever they're treated. I'd like to thank everybody for the opportunity to speak today on rural trauma and disparities, and hope you enjoy the rest of this APSAsode. Thank you.
Good morning. I'm Chad Thorson from the University of Miami.
I'm Kim Wallenstein from SUNY Upstate University.
Today, we're going to talk about the psychological sequelae of trauma. Although trauma centers are well equipped to deal with violent injuries, historically, they're not as well equipped to deal with mental health issues from repeated violence. With high rates of re-victimization and cumulative violence exposure, the risk for exacerbating mental health conditions is exponential. PTSD and depression are seen in about 20 to 50% of pediatric trauma patients. Studies have identified as well that the more you screen, the more you find. If untreated, these mental health conditions have major risk of ongoing physical recovery, social functioning, and impacts on quality of life. Pediatric patients are different than adults in many ways, and they display a broader range of signs and symptoms that are often missed by healthcare practitioners. The implications are wide. Up to 80% of children experience some trauma before adulthood. This leaves them at risk for developmental delay, substance abuse, lack of impulse control, and suicide. Although there's no correlation with severity of injury, there's one exception, and that's disfiguring injuries and traumatic burns, where the rates of ongoing psychological distress are the highest. Other potential risk factors involved are socioeconomic factors, race, gender, and age. Importantly and most consistently, the response of a child's parent or primary caregiver impacts the risk to that child. So why does this occur? The sympathetic nervous system is meant to deal with the fight or flight response. With PTSD and depression, this is augmented compared to the normal response. In addition, the hypothalamus is overactive, leading to high cortisol levels, and these are found in patients with these mental health conditions. Children present with atypical symptoms compared to their adult counterparts. They may have repetitive play, avoid stimuli, throw temper tantrums, have difficulty sleeping, and especially in young kids, they have a very difficult way to describe flashbacks. So how do we diagnose PTSD? Well, first there has to be an exposure to a threat that causes severe injury, sexual violence, and these are usually directly experienced or witnessed by the child. Followed by the traumatic incident, they have intrusive symptoms with recurrent distressing memories, flashbacks, dreams, intense or prolonged psychological distress. And then this leads to avoidance of stimuli that arouse recollections of this trauma. So they avoid places, people, conversations, and other interpersonal situations. There also is a negative effect on the cognition where children have more fear, guilt, sadness, shame, or confusion, and may become fully socially withdrawn. Lastly, the arousal and reactivity are heightened, such as sleep disturbances, irritable behavior, angry outbursts, hypervigilance, and exaggerated startle responses. One of the best ways to diagnose PTSD is the Child PTSD Symptom Scale, the CPSS. After identifying a trauma, this is a list of 20-something different questions the child is asked, and they rate between 0 to 4, from not at all to nearly always. Once all these questions are answered, you can get a severity to understand how severe the child's PTSD symptoms are. Unfortunately, PTSD and depression may lead to more severe sequelae, such as suicidal ideation and behavior. Rates have gone up by 1/3 in the last 20 years. It's one of the top 3 causes of death for adolescents and young adults, and 80% of those who die by suicide have contact with a healthcare provider within months of their death. Because of this, the NIH and the National Institute of Mental Health have developed the ASQ, or the Ask Suicide Screening Questions. The Joint Commission issued a Sentinel event alert regarding suicide screening that all medical patients in hospitals should be screened at least once. Questions are related to thoughts of death and the frequency of these thoughts. And if patients screen positive, they should have a mental health full evaluation.
So now I'll switch gears and let's talk about a recent phenomenon which may not be considered when thinking about traumatic stressors. And that, of course, is the COVID pandemic. The pandemic doesn't fit traditional models of PTSD, although previous studies done in epidemics like SARS and MERS did find mental health problems in survivors. And mental health problems have also been seen in those not directly affected by the pandemic. Most PTSD models attribute traumatic stress reactions to past events. However, recent studies, including one from this year, showed that traumatic stress reactions do occur to future anticipated events which have not yet happened. And indirect exposure to things like social media can trigger stress reactions. Participants had stress symptoms for events that had not yet happened, and this was with or without exposure to the actual COVID virus. So there has been coined a term post-COVID stress disorder. The pandemic has been linked to diverse mental health problems such as anxiety, depression, PTSD, and other post-traumatic stress-related disorders. There are traumatic stressors such as illness, hospitalization, and being part of a death. And then general stressors like the exposure to the virus, social isolation, employment loss, and different medical situations. There are some protective factors. People do have good social support, financial stability, good healthcare resources, safe workplaces, and if they have wellness programs in existence and adequate PPE, those are protective factors for stress. So the one report that came out last year from the CDC was a web-based survey of over 5,000 adults. It was interesting that related to the pandemic, over 40% of those that filled out the survey endorsed at least one adverse mental or behavioral health problem. Trauma or stress-related disorders were present in over 26%, anxiety and depression over 30%, and suicidal ideation in over 10%. And it was concerning that this was higher by more than double in younger responders, which in their study was youths age 18 to 24 years. So this hits a little close to home. Healthcare workers have been affected, obviously, by the COVID pandemic. International studies have examined the stress responses in healthcare workers treating patients with COVID-19. Several studies have looked at this internationally, and several studies have shown that there were stress responses in healthcare providers. In one study, Sims et al., a British study of military healthcare workers, inadequate safety equipment had greater odds of producing mental health disorders. And a study of nurses in China found over 16% incidence of PTSD. There's obviously a concern for the pandemic creating increased suicide risk among healthcare workers. It is noted that healthcare workers already have an increased risk of suicide. And one study from last year did review several cases of nurses who committed suicide in cases related to the pandemic. Children also have pandemic awareness and responses. It is noted that children with adverse childhood experience have risk of physical and mental health issues, and this pandemic can be considered an adverse childhood experience. Studies have also shown that social isolation is predictive of future mental health problems, with the duration of that isolation being strongly associated. These several studies looked at children across the world who were in quarantine and found that there was a great prevalence of post-traumatic stress symptoms and mental health problems in children in quarantine. Obviously concerning is the potential for increased suicide in children related to the pandemic. It's noted that the most frequent method of suicide in children is hanging. Predictors are perceived stress, family conflict, exposure to violence, bullying, and mental health disorders such as PTSD and anxiety. And these things can be exacerbated by this pandemic and the social isolation and quarantine. So during the pandemic, the family is quarantined. So you can see that there are some negative factors associated with that, like the lack of their peers, the risk for parental problems such as parental mental illness, the greater risk of potential child abuse, and social isolation. There are some positives that are noted, such as they have a little bit less academic and social pressures because they're not in school. And if the family is a cohesive unit, they can have a strong social support. It is interesting that despite sort of anecdotal reports of increasing suicide rates in children during the pandemic, Studies so far have not yet found a significant increase during this time. So what interventions can we use? With medical caregivers, there's ways to address burnout, ensure adequate PPE, ensure childcare services, and feedback sessions. For survivors of COVID, physical therapy and psychotherapies are useful. And with children, it's important to provide developmentally appropriate information. So depending on the child's age, they can get different amounts of information about the pandemic that helps them be more reassured about the future. Parental support and reassurance is important, as well as teaching coping strategies and consistency. Healthcare providers can inquire about mental health and encourage parents to seek evaluation for children if there are any concerns. So in summary, for both of our talks, mental health issues are common after trauma. Screening for PTSD, depression, and suicide risk is key, and the COVID pandemic has resulted in an increase in mental health conditions.
Hello, I'm Ken Satterley from the University of Vermont, and I'd like to thank APSA for the opportunity to speak today about pediatric traumatic brain injury, the Brain Trauma Foundation guidelines, and where and why we stray. My interest in this topic stems from my participation in the adult and pediatric PI programs at my institution. Usually when we're discussing the care of traumatic brain injury, the neurosurgeons bring up the traumatic brain injury guidelines, and they almost have an aura about them as if they were divinely provided. This has led me to look into where these guidelines came from, whether they help, and whether we remain faithful to them in the care of our patients. As part of this, I'd like to speak about traumatic brain injury, the Brain Trauma Foundation, and the 2019 guidelines, what has changed from what previously had been recommended, and where we as providers deviate from these guidelines. Some background: pediatric traumatic brain injury is the leading cause of pediatric trauma deaths. The CDC estimates that 7,000 children die annually from brain injuries, and that children less than 4 have the highest incidence of hospitalization and death from brain injury, except for those age 75 or older. We classify brain injury based on Glasgow Coma Scale, and severe injury, which we'll be talking about today, is Glasgow Coma Scale of less than 8. Severe TBI accounts for 2 to 5% of pediatric head injuries, but has a mortality of nearly 50% and extensive long-term morbidity. Severe traumatic brain injuries is present in approximately 2 to 4% of admissions to pediatric trauma centers, which means many centers will see less than 10 a year. Of children dying of traumatic brain injury, 50 to 80% have signs of secondary brain injury. Secondary brain injury results from events that lead to reduced perfusion of the brain in metabolite delivery and clearance of toxins. This can lead to vasogenic and cytotoxic cerebral edema, elevated intracranial pressure, and worse outcomes. The Brain Trauma Foundation was founded in 1986 to study brain injury. They have issued guidelines in 2002, 2012, and 2019 for pediatric brain injury care, and these are really directed at limiting secondary brain injury. The 2019 guidelines were published in Pediatric Critical Care and are available online. The full guidelines are over 80 pages. There's a shorter executive summary. And one thing included in the 2019 guidelines included a bedside algorithm to provide real-time care. The authors do acknowledge that there's significant gaps in knowledge and that there's hopefully results from an upcoming trial completed in late 2019 that'll address some of these areas. The Brain Trauma Foundation guidelines, there are 22 recommendations based on 15 areas of interest, and these are further under the headings of monitoring, threshold, and treatment. The quality of the guidelines is relatively poor, as we mentioned previously, that 85% of the guidelines have our level 3, which comes from a low body of evidence. I want to take a step back for a minute and talk about several of the basics. And these are really essentially legacy guidelines that aren't specifically noted in the current guidelines, but things that are considered standard of care for all traumatic brain injuries. And these include intubation for those with a Glasgow Coma scale of 9 or less, elevation of the head of the bed, euglycemia, and control of anemia and coagulopathy. These are some key points that may be of interest to people for us as surgeons who are involved, especially in the early care of these patients. And these are points from the 2019 guidelines. There's continued recommendation for ICP monitoring of all patients with brain injuries with a Glasgow Coma scale of less than 9, and the threshold care values for ICP remain keeping the ICP less than 20 and the cerebral perfusion pressure of greater than 40. There's a new level 2 recommendation for the use of bolus 3% hypertonic saline for ICP control and this is recommended over the use of a continuous infusion of 3% hypertonic saline. The guidelines do not recommend the use of prophylactic hypothermia for the treatment of traumatic brain injury. There is a caveat for that in the second-tier therapies, there is a potential role for hypothermia in the treatment of refractory elevated intracranial pressure. There are no new or revised recommendations regarding barbiturate, coma, or decompressive craniectomy. I mentioned these algorithms, and when you look at these slides, these are fairly intimidating and can look at pretty busy slides. First-tier therapy is really based on 4 pathways. There's a pathway for acute herniation. There had not been anything published on this before, but that gives recommendations on what to do when the child appears to be herniating before your eyes. The second pathway is based on ICP, the third on CPP, and the fourth on tissue oxygenation or brain tissue perfusion and oxygenation for those that have things such as Lycox catheters in place. And as said, these are based on guidelines and expert opinion. This may look familiar to you. This is a cartoon from earlier this year from the APSA Space Learning Program that really distills down the ICP pathway and the CPP pathways of the bedside care algorithms. I showed this to a neurosurgical colleague, and her comment was, this is really pretty nice. It ought to be labeled brain injury care for dummies, which, considering that was from a neurosurgeon, I took that as a compliment, but this is really a great practical guide, and APSA should be congratulated for producing this. The second tier therapies are from when the ICP is refractory to first tier therapies and includes decompressive craniectomy, barbiturate infusion, moderate hypothermia, hyperventilation, and pushing the osmolarity to at least 160. Well, adherence to these guidelines, does it improve outcome? In 2007, after the first set of guidelines were released, the CDC estimated that there'd be a dramatic improvement in outcome and saving of money. There have been several studies that suggest that implementation of a comprehensive multidisciplinary brain injury program that incorporates the Brain Trauma Foundation guidelines leads to improved survival and increased functional outcome at the time of deviation or discharge. So if these Brain Trauma Foundation guidelines seem to help as part of a program, why do we deviate from them? If we have a great working tool like a fire extinguisher, what leads us into trouble with it? Well, trying to find exact data in the literature on where deviations occur and how they occur and why they occur is difficult. ICP monitoring is the most common deviation from the guidelines, and by extension of this would affect guidelines for CPP management. In the pre-hospital phase, it appears that hyperventilation is the most common deviation. Seizure prophylaxis and delay in starting nutrition occur in about a third of patients from what can be found. And often these deviations, again, will most practically come up for you in your trauma PI program. I want to focus on ICP, and the reason is that the guideline recommendations for really all of the guideline recommendations from the Brain Trauma Foundation center on ICP. The recommendations for sedation, hyperosmolar therapy, ventilation, barbiturate use, they're all ICP based. The problem is the data on ICP monitors is mixed. There's no randomized controlled trials, and though many studies suggest improvement with using monitors to guide treatment, not just the presence of a monitor, but to guide treatment, there's enough evidence that led the Brain Trauma Foundation to provide a level 3 recommendation. But there are also studies that show that there are no improvement with use of ICP monitors, and that they increase the length of ventilator days, length of stay, and use of hyperosmolar therapy. That being said, there are no published protocols for managing severe TBI in children without ICP measurement. A trial in adults that went down to as low as age 13, comparing ICP monitoring versus clinical exam and imaging-based assessment of intracranial hypertension was done. Interestingly, this showed no difference in outcome. Well, if you look at ICP monitoring, this is data from the 2020 fall TQIP benchmark, and it's data from all ACS verified level 1 and 2 pediatric trauma centers in the US. ICP monitoring was only used in a third of patients. My institution wasn't much better. We were 36%. Data in the NTDB and the Pediatric Health Information System databases show that individual hospitals, the rates of ICP monitoring is 6 to 50%. It's even worse for the use of brain oxygen monitoring. Why aren't ICP monitors placed? Most common reasons are neurosurgeon practice preference. The neurosurgeon has deemed that the brain injury is not survivable, and therefore they feel that no intervention, that an invasive intervention is not indicated. The patient undergoes a decompressive craniectomy. Immediately and following this, the neurosurgeon's practice pattern is not to place ICP monitors. Uncorrectable coagulopathy, patient improves rapidly, and sometimes the reasons are just unclear. The NTDB and pediatric TQIP do not list the reasons for not placing a monitor. So deviations from guidelines. Within the specific literature trying to find about deviations, there's very little written as to why really this happens. Factors identified in systems in difficulties implementing pathways and protocols in healthcare have included provider knowledge deficit, provider culture, lack of resources, institutional culture, poor team communication, and patient-specific reasons. Really, my patient is different, or they'll have an ileus, so I'm not going to start nutrition, or the family doesn't want it. Well, in conclusion, the Brain Trauma Foundation guidelines provide a foundation for developing a hospital-wide integrated program for management of traumatic brain injury. The guidelines provide a framework for the Pediatric Trauma Center PI program to evaluate the care of children with traumatic brain injury. And though the Brain Trauma Foundation guidelines are evidence-based, the evidence is weak, and there are significant knowledge gaps. The guidelines may change dramatically in the future as better data becomes available through studies such as the ADAPT trial. I thank you for this opportunity to speak. Thank you.
Good morning. I'm Chris Newton. I'm one of the other pediatric surgeons on the trauma committee, and I've been asked to spend a brief amount of time talking about an update in pediatric disaster care within the U.S. and the programs that have been developing over the past year or more. So I'm not going to get into great detail. Certainly, if we began to cover all of the tools and programs that we're involved with as pediatric surgeons around the country, I would undoubtedly exceed 10 minutes. So rather than doing that, I really want to focus just on providing the resources and the information of what's out there, and hopefully inspiring the community to engage and get involved with these things. So as background, pediatrics children represent 25% of the US population. It's been appreciated for a long time now with a lot of examples in various disasters that when something happens, whether it's a hurricane or a fire or a pandemic, children are often disproportionately impacted, and especially families. So a great deal of passion and discussion over the past 20 years or so has engaged the government in trying to create programs to improve this and impact this. This has led to a lot of restructuring of the government and the federal programs. And some of them are fabulous and are designed for kids, and pediatric surgeons should be a part of this. When you begin to look at this federal infrastructure, I will acknowledge the complexity is overwhelming. The acronyms are confusing, and it's not clear who's in charge of doing what. So in some level, you have to read through all of these acronyms to find the right program. However, pediatrics is sprinkled throughout all of these. So don't look too far. Most of the programs we are talking about here today are within Health and Human Services and ASPR. That's the Assistant Secretary for Preparedness and Response. The ASPR and NDMS and regional programs really right now is the foundation for most of disaster preparedness and response in the U.S. There are others, and it's not just HHS. HRSA has quite a few fabulous programs as well. And if you don't know these programs and acronyms, I encourage you to look them up, especially the NPRP program for PEDS readiness and the EIIC. Tremendous amounts of resources and information on those websites. And these are things that can help your local hospital and your community. The federal response infrastructure conceptually is divided up into 3 tiers. So at the first tier, of course, is first responders, local community hospitals, local county agencies. And at the very highest tier is the federal resources. So this is the Department of Defense and the federally sponsored tents that set up ancillary hospitals and convention centers. In the middle is this concept of a regional coordination center. There are 3 in the US that are both adult and peds that are not peds specific, and 2 centers in 2019 were opened and funded by the federal government to focus just on kids. So one is the Eastern Great Lakes Group that's run by Deanna Dalgrove in Ohio and Michigan, and Charles Macias. The other is my group on the West Coast. And I'll talk about that in just a moment. I do want to note once again for reference, if you're not within these states that I'm talking about, the Boston, Nebraska, and Colorado groups, these are the regional disaster coordination centers. Those centers do have PEDS programs integrated within what they do. So if you are in one of those states, please find that center, engage with them, be the pediatric surgeon voice within their organization. So the West Coast group encompasses 5 states. It's Washington, Oregon, California, Nevada, and Arizona. And you can see that it encompasses a consortium of all sorts of different folks. We have representatives from most of the academic pediatric hospitals, as well as a lot of agency folks from county and state organizations, from the poison control centers, from transport facilities, both public and private, and healthcare systems like Kaiser. So all these myriad of folks got together and decided to go for this funding, and we were fortunate enough to get it. And now we've spent about 1.5 years trying to piece together the foundations of how we take care of kids across state lines in a disaster. And of course, COVID hit in the middle of all of these efforts. So we began our project with dividing up into multiple different focus groups that look at all sorts of different things. This was very effective because doing it all at once is very overwhelming. So each state sends representatives to look at each of these different niches and once again try to look at not just the local problem, but how the efforts coordinate and how they integrate in different jurisdictions. We developed a web portal. This is not only for putting information out to the general public, but more importantly, this is our platform for communicating with each other. This is where we share information and data and calendars and projects that are ongoing. Once we develop this community within our West Coast states, I then found interestingly that some of the inspiring efforts expanded even beyond our group. And this went to integrating and coordinating national societies and federal programs and integrating with all sorts of different groups. And you can see a list of a few of them here. The list goes on beyond this. But as an example, this includes things like us working with APSA, with the Trauma Committee and the Quality and Safety Committee, and with David Powell in the middle or the beginning of COVID to pull information from all over the country of what is best practice and what is everyone doing, and creating video vignettes of surgeons talking about their experience and how they're dealing with COVID. This integration kind of effort to me has been quite profound, and it is getting more extensive as the days and weeks go on here. All of these efforts, whether it's within our local group in Eastern Great Lakes or the West Coast or national societies, the end result has been a whole flood of products and pages and toolkits and info, and this has begun to populate all these websites. I want to give this not necessarily to get into the details of what these projects are, but to give you the links and the resources of where it's all listed. So you'll see our website there. That's one of them. EIIC is tremendous. The APSA library pages, if you don't go on and look at stuff, please take a look. They're amazing. As well as the Ask for Tracy site, which has all the free stuff that we provide to them. And then as part of the inspiration, once again, I want to just point out a few of the federal groups. The PEDS Readiness Group, the National Site Survey Program begins this May. If you're not doing this in your community hospitals, please encourage them to do it. The NACCD is the National Advisory for Children in Disasters. This was instituted in the Obama administration, was quiescent for several years, and now is being reestablished. Keep an eye on this. That committee, I think, has a very profound voice in DC for our kids and our community and what we're doing. And as I said, take a look at all the federal programs that are operating within your state and within your region. I will also encourage you, most of the APSA community here is also involved in other societies. Take note of how the programs in each of the societies align and integrate and help each other. There's lots of stuff going on within AAP and AAST and the PEDS Trauma Society and the American College of Surgeons and APSA. And as all of these programs look very much alike and people populate each of the committees, I think all of the projects are growing together and doing a lot of the same things. Finally, I want to inspire folks to look at the funding mechanisms that are coming down the pipeline. When we're talking about children in disasters, those funding mechanisms right now are very robust. There's a lot out there. In particular, there's a lot out there looking at equity and diversity and underserved populations and access. And I think this is because, especially over the past year, we have appreciated the fact that those issues impact every single project we do. There's no focus group or special interest group that does not have to think about this and address it and try to improve the community and the environment. We're not going to get into questions with this now. I'm happy to answer more offline or with the other speakers, but I in particular wanted to give my contact info. And if anybody wants to get plugged into any of these groups, please let me know. I'm happy to guide you the right direction. Thank you very much.